We are back on the record at 11:50 a.m.
Doctor, can you tell me what your knowledge was of the drug Kexlate when you ordered it for Dennis Allen on March 18, 2013?
Objection as to the scope of that. You can answer.
Could you be more specific?
I want to be as general and as broad as I can because I want you to tell me everything that you can remember about your knowledge of the drug Kexlate, what it does, what it's used for, the risks, and the benefits.
Objection as to scope and form, but you can answer.
Okay. Kexlate is an oral medication that's used to decrease the total body potassium or increase the clearance of potassium from the body when it's elevated. It works by exchanging potassium and sodium in the lining of the gut. It's typically reserved for cases where the level of potassium is sufficiently high to cause changes in the membrane of the electrical system of the heart, resulting in visible changes in the EKG or heart monitor. And it can take between an hour and 24 hours to have an appreciable effect. In my experience, it can work more rapidly, especially if someone's already having frequent bowel movements. What else would you
Risks.
like to know?
The risks, if you will.
At the time that I administered Kexlate to Mr. Allen, I was not aware of any appreciable risks.
Well, how do you find appreciable?
I would define it as a risk that would outweigh or affect my decision to give that medication in a certain circumstance.
Well, if we take out the qualifier appreciable, can you tell me all of the risks that you were aware of that could pose a harm to Mr. Allen by ingesting Kexlate?
Objection as to form.
I don't recall any risks that came to mind.
Then would it be fair to say from your medical school education, internship, residency program, you were not instructed on the risks of administering Kexlate?
Objection as to form. You can answer.
I would say I do not recall any instruction on risks.
And you were not aware of any at the time that you administered them to Mr. Allen. Would that be a fair statement?
Objection.
That is a fair statement.
Okay. All right. So, and would it be fair to say that when you administered the Kexlate to Mr. Allen, you weren't aware whether or not the Kexlate at the hospital was mixed with sorbitol or another substance?
Correct. It was not, as evidenced by the order sheet,
And
delineated whether sorbitol was included in that
Right.
mixture or not.
And you made no specific request that the Kexlate to be administered to Mr. Allen did not contain sorbitol, did you?
No, sir.
Okay. All right. Now, had you ever administered Kexlate before for the treatment of acute hyperkalemia?
Yes.
How many times?
I would say between 10 and 20 times.
Were those patients in kidney failure and renal failure similar to that of Mr. Allen?
Some, but not all.
Were those patients in kidney failure and renal failure to the extent that Mr. Allen was?
I don't know if I can answer that question. Each patient's individual. Perhaps if you could be more specific.
Just from your memory, doctor, I don't know the patients you've treated. I'm just asking if you can remember.
Well, again, it's a very general question. If you mean, have I administered it to patients who have required dialysis, then yes, I have.
Okay. Have you administered Kexlate to patients who had similar conditions, which would be kidney failure, renal failure, and evidence of an interference with the electrical charges in the heart?
Yes.
Okay. And do you know how many times?
No.
Okay. Now, doctor, on the order set, oh, I'm sorry. Did you, the reason that the hyperkalemia order set was generated by the computer, did you type in the word hyperkalemia as a possible diagnosis for Mr. Allen?
I don't recall how the order set was specifically generated in this case.
Okay. Well, is there anyone other than you that would have put information in the computer to have generated the order set for Mr. Allen?
No.
Okay. So at some time on the 18th, between the hours of 12 and 1 o'clock, did this order set pop up for you?
Yes, sir.
Okay. And then did you follow the order set for the treatment of Mr. Allen, at least to some degree?
According to this order set, the things that I ordered for him was an EKG, which was obtained and showed the concerning changes.
Okay. Now, I just want to stop you there for 1 second. Did you reach the differential diagnosis of hyperkalemia before or after the results of the EKG, which I think was around 12:23 that afternoon?
Prior to.
Okay. Can you tell me the reasons why you reached that conclusion prior to ordering the EKG?
Mr. Allen was being monitored on a continuous telemetry monitor, which is a heart rhythm monitor. That is another way to monitor the electrical activity of the heart. And that showed me, also showed me signs that hyperkalemia may be occurring. And that was brought to my attention around noon by Mr. Allen's nurse.
Was that the bradycardia?
That was one of the findings that was concerning.
And what were the other findings that were brought to your attention by the nurse?
Well, it was an erratic rhythm. He would be bradycardic, sometimes he would be tachycardic. The intervals within the heart rhythm itself, the specific waveform of the heartbeat were abnormal, and those other things.
And do you know what time of the morning that the nurse noted these changes on the telemetry monitoring?
I don't know what time she noted it specifically. I know the approximate time I was notified was around noon.
Okay. Now, are these images, the telemetry images, are they constantly being recorded for the record, or does the nurse have to print a button and have them printed out in order to be included in the patient's chart?
Well, both. The monitor will automatically print an abnormal rhythm itself, and then also the nurse can print and include it.
So there's parameters in the software program for the telemetry that the computer automatically prints an image when there's an abnormal response?
I would assume.
Okay, and that's your experience at the hospital?
That's my experience, is that
Okay. Do you know if you looked at any of those abnormal images before 12 o'clock, before the nurse brought them to your attention?
no.
Okay, all right. So based upon the nurse's evaluation and bringing it to your attention, then hyperkalemia was part of your differential diagnosis before you ordered the EKG.
Yes.
Okay. Now, did you want to wait until after you got the results of the EKG before you changed his medication?
Yes, typically.
Okay. And what were you looking for the EKG? What was the EKG going to show you that the telemetry would not?
The EKG gives a more detailed image of the heart rhythm and the wave, the electrical wave that goes through the heart at the time of a heartbeat. Specifically, what we call a peaked T wave, which is not often as clear on a telemetry monitor.
All right. And was the EKG concerning for you?
Yes.
Okay. How so?
It contained all of the signs that we've already mentioned. It had the bradycardia. It had the first and foremost. It had the peaked T waves, which certainly makes hyperkalemia very concerning. What was more concerning and made the situation more emergent was the prolongation of the PR interval and the widening of the T wave, which suggests that Mr. Allen was developing an unstable cardiac rhythm, and the most likely source of that was the hyperkalemia.
This would be a typical or a classic response of the heart to elevated potassium levels.
Objection is to form.
It's a tip, and again, that's going to depend on each patient. Now, some patients who have a slow rise in their potassium over time, the heart, the membranes of the conducting system in the heart can become accustomed to it and show much less severe changes, or not show any changes at all. They can have, the only reason you find the hyperkalemia is because it appears on a lab. Then in patients whose potassium is rising at a much faster rate, they will typically then show these findings. And these findings that I appreciated in Mr. Allen suggested that his potassium was at a very high level and had gotten there fairly rapidly. I would say less than 12 to 24 hours. And that required emergent treatment.
And doctor, in your experience, what is the fastest way to counteract the effect of the patient's heart, in this case, Mr. Allen's heart, as a result of the unusual electronic waves that were caused by the elevated potassium levels? What's the fastest way to counteract that?
Best or fastest?
Fastest.
Objection is to form.
So the fastest way, there's multiple ways to do that, and it's the first thing that you want to do is provide intravenous calcium, usually in the form of calcium gluconate.
Okay.
And that is meant to stabilize the cardiac membrane. It's a very transient effect, though. And then the other ways would be to try to shift the potassium from the blood into the cells of the body using insulin with glucose, sodium bicarbonate, and albuterol, all of which are here on this care set.
Okay. So if you had your choices, it would be the calcium gluconate first, then a combination of insulin with glucose, sodium bicarbonate, and the albuterol?
I can't agree with that statement because in these situations, and specifically Mr. Allen's situation, it was such an emergent situation that all of those would have been ordered at the same time.
At the same time?
Yeah, so you don't wait. I would not have waited for one to happen because you're not fixing the underlying problem by doing any of this.
Right. And
you're just trying to prevent a worsening of the heart rhythm.
And would you agree that the underlying problem in this case is the rhabdomyolysis that actually was a cause of the increased potassium levels in Mr. Allen's body?
Objection.
I'd say without full certainty, I can't say that, but that's the most likely reason. It was the breakdown of his muscle, which then released potassium into the blood and resulted in a elevated potassium level.
I'm just asking you for more likely than not, the rhabdomyolysis was a cause of the elevated potassium levels. Would you agree?
Yes, sir.
Okay, now, all right. So you're not curing the rhabdomyolysis, you're just treating the effects of the potassium on the heart.
Objection.
No, sir.
I'm sorry?
I'm sorry.
Go ahead.
So,
Maybe I misunderstood. I thought you said that the reason for administering the calcium gluconate, the insulin with glucose, the sodium bicarbonate, and the albuterol was to treat the adverse effects that the elevated potassiums are having on the heart, but you're not actually treating the underlying cause of that. Did I have that correct?
you had that correct.
Okay.
But to be more specific, so we're getting into very specifics here about the case. When I said that you're not treating the underlying cause of what? The underlying cause of the cardiac arrhythmia, the abnormal heart rhythm. The underlying cause of that is the elevated potassium level. By giving calcium gluconate, by giving albuterol, by giving insulin and glucose and sodium bicarbonate, you're not curing the hyperkalemia. You're one, trying to stabilize the cardiac membranes with the calcium gluconate, and two, you're very temporarily pushing the potassium out of the blood so that the cardiac cells don't see it. That's a rapid, temporary way to buy time while you fix the overall problem, which is an elevated total body potassium that's in the bloodstream. And then the way you do that, there's three options, and that would be the K-exalate, furosemide, and dialysis. Furosemide wasn't an option because that only works through the kidneys, of which we've agreed his kidneys were not working. And both of the other two options require time.
Okay. And in my hypothetical, assuming once you reached your differential diagnosis of hyperkalemia and they could have started dialysis within 10 minutes of the stat order, what is the period of time Mr. Allen needed to be under dialysis in order for it to effectively reduce the potassium levels in his body?
I don't understand the question. We didn't agree that the dialysis could begin within 10 minutes.
That was my hypothetical. I'm assuming that he can start dialysis within 10 minutes after you spoke to Dr. D. What period of time did you expect, Mr. Allen, if he was under dialysis, for that to have reduced the potassium levels so that his heart condition was no longer an emergency?
Objection as to form and foundation. You can answer.
Without being as well versed in dialysis, I know typically they would do a 4-hour session in order to lower the potassium.
Doctor, did you know when you treated Mr. Allen how quickly the potassium levels would drop in his body for every 15 minutes or 30 minutes he was on dialysis?
No, sir.
Okay. All right. Doctor, when you treated Mr. Allen, did you have any idea how quickly the potassium levels would be reduced in Mr. Allen's body simply by administering K-exalate, whether it be half hour, 2 hours, 4 hours, 8 hours?
Objection as to form. You can answer.
I don't know specifically because every patient responds differently to medications, and as I said earlier, Kexlate has a very wide range of action. My hope in giving it to Mr. Allen was that it would work rapidly within an hour. Because without a rapid lowering in his potassium, his heart rhythm was almost certainly going to become fatal.
So it was your belief when you had ordered Kexlate from Mr. Allen that within 1 hour after ingesting the Kexlate that his potassium levels would be reduced enough to eliminate the emergent heart condition.
Objection.
Is that correct?
I would not say that it was my belief. That was my hope. That was my intention.
All right. What was your belief?
I think that's been asked and answered. Objection, but you go ahead.
My belief as far as what would happen after I gave the Kexlate?
Yeah. What I'm trying to figure out is, did you have an understanding in the field of medicine that once you give a patient Kexlate, what is the drop of potassium in the patient's body for every hour after the patient is administered Kexlate? Did you have an understanding in the field of medicine how that worked?
I can't give you an hourly drop necessarily.
Can you give me a 2-hour drop, a 4-hour drop, an 8-hour drop, any type of quantification?
Objection. You may answer.
To the best of my recollection, the drop I was anticipating was at least 1 milliequivalent of potassium. And we hope...
I'm sorry, 1 mil equivalent?
Milliequivalent.
Mil equivalent.
Yeah.
Over what period of time?
That I wasn't sure of. That I was hoping was going to be on the shorter end of the spectrum, given the fact that he was having regular bowel movements.
Well, can you cite to any medical article or study or textbook where you gained the information that you just testified to about a potassium drop of 1 milliequivalent over a particular time period?
Not today. I can't cite that for you today.
And were you even aware of it when you treated Mr. Allen?
I was aware of it, yes.
Okay. But you can't tell me how.
Not specifically. I can't give you a specific article.
Okay. And how much did Mr. Allen's potassium have to drop in order for him to be out of immediate danger?
That I don't know. Any drop was going to decrease his risk of a fatal arrhythmia. Because the assumption was that his potassium was rising and continuing to rise, and that was what was contributing to the worsening of the arrhythmia.
Right.
If the potassium rises and stops rising, eventually the heart rhythm will the membranes in the heart will stabilize and get used to that level of potassium. And you can see that with people who have peaked T waves, and they can have those for many, many hours, for long periods of time, because their potassium levels stabilize at a certain level. And those eventually will go away, the T waves. But in Mr. Allen's case, he had progressed beyond the simple peaking of the T waves. He was now getting into the point where it was affecting his heart's ability to pump effectively. And that can only happen if the potassium is continuing to rise. So any intervention that would halt the rise of that potassium level or decrease it would decrease his risk of a sudden cardiac death from that arrhythmia.
But you don't know how quickly that was going to be accomplished by the use of Kexlate in this case. Would that be a fair statement?
Objection. You can answer.
That's a fair statement.
Okay. And because you didn't know the risks associated with Kexlate when you recommended it for Mr. Allen, would it be also fair to say that you didn't explain to Mr. Allen the risks of taking Kexlate?
Objection.
I would say I did not explain the risks to Mr. Allen, as you said, because I was not aware of them. Had I been aware of them, given the emergent case and the emergency, or the emergent nature of the situation, I would have not discussed that with him either at the time.
Even if you were aware that Kexlate could cause ischemic bowel and possible death in the most serious cases, you would have withheld that information from Mr. Allen?
Objection as to form.
In the situation in which the heart rhythm was almost certainly fatal, then yes. The risk, and to be clear, it's really been described as an association between bowel necrosis and Kexlate. There's never been anything to describe it as truly a causal factor. And even so, that association is so rare, given the millions of times how frequently Kexlate's given, that risk compared to an almost certain cardiac arrhythmia, death, that risk was immaterial to me. That risk for me was not significant enough that it would have warranted me explaining that to him.
But
I'm sorry, are you finished?
Yes, for now.
Right.
Okay, but you didn't know that risk at the time you administered the drug then, right?
Objection.
That's correct. I did not know that risk, but had I known it, it would not have changed my actions.
Okay. All right. Did you place an order for calcium gluconate?
Yes.
Was the pharmacist able to comply with your order?
No, sir. There was a national shortage of calcium gluconate.
And how did you know in this case that the pharmacy did not have calcium gluconate?
I spoke with them directly.
Okay. And what did he tell you? Or she, I'm sorry.
That there was a national shortage of calcium gluconate.
Did you ask the pharmacist, do you have a suggestion as to what other alternative drug we can use in this case other than calcium gluconate?
That would have been calcium chloride.
Okay. Did the pharmacist acknowledge that they had a supply of calcium chloride in the hospital on that day?
That I don't recall.
Would it have been something important for you to know?
Objection.
It would have been something important for me to know, but it would have also, I ordered calcium chloride
When?
at the same time, immediately following that conversation with the pharmacist.
Okay. I can't find that order in the record, doctor. Can you tell me where that order appears?
I can't explain that.
Are you telling me that you ordered calcium chloride for Mr. Allen when the pharmacist told you that calcium gluconate was not available and no one in the hospital complied with your order?
Objection.
No, I'm not saying no one complied with my order. I'm saying in emergent situations, there are times where documentation may take a secondary role, and therefore things may not be accurately documented. But in this case, calcium chloride would have certainly been ordered.
And did you order calcium chloride for Mr. Allen?
Yes.
And the reason you ordered calcium chloride for Mr. Allen, because if the pharmacy in this case did not have calcium gluconate, calcium chloride would have been the next most appropriate treatment to reduce the levels of potassium in his body. Would that be a fair statement?
Objection. Go ahead.
No, because the intent of calcium chloride is not to lower the levels of the potassium in the blood. It's to stabilize the cardiac membranes. But if you're saying that in the absence of calcium gluconate, the only other option for stabilizing the cardiac membranes would be calcium chloride, then yes. Calcium chloride is the only other IV form of calcium that I am aware of.
Okay, so in this case, would it be fair to say, because the hospital did not have calcium gluconate in the pharmacy, that calcium chloride was the next best, fastest way to stabilize the cardiac membranes in Mr. Allen's body?
Objection. You can answer.
Yes, it's the next most appropriate way, but again, these are very temporary measures.
Okay. Now, when you ordered calcium chloride, at what time after you placed the order did you place it on a stat basis?
Yes.
Okay. At what time after you placed the order on a stat basis did you expect that calcium chloride would be administered to Mr. Allen?
Within 10, 15 minutes.
Was the calcium chloride ordered, well, let me ask you this. Would it have been ordered the same time you ordered the calcium gluconate, which would immediately after that order?
It would have been immediately after I spoke with the pharmacy and was aware that there was no calcium gluconate available.
Okay, and it looks like your order for calcium gluconate stat was made, it's on page 363, around 12:37?
That's going to be a very different,
Yeah, I can.
it's going to be very different than ours. Sure.
So look at page 1402 of our records.
1402 of ours.
That's what you're looking at?
It's probably the same.
Actually, at the bottom of the University of Maryland Medical Center records, it's page 163 of page 265, printed on June 25, 2015.
1402, based on our numbering system.
Right, our bait stamp.
And I have a different page. I have, with the little numbers you're looking at the bottom,
Right.
Counselor, I have page 153 as the actual order for the calcium gluconate.
They must have printed it out different
Is
times.
my numbering correct? I mean,
No.
I'm sorry, it's not. It doesn't. We don't match.
We don't match.
All right, what I'm going to do is,
Mine also says 163 of 267.
as long as you're
And it
looking at the
says-
order for calcium gluconate, then then we can agree.
My order, the one I'm looking at says that on March 18th, 2013, calcium gluconate was ordered on 12/37/57.
All right. Is that the same order that appears on page 363
Correct.
of my binder? Okay.
This is the same.
All right, Doc, so we can agree that around 12:37, that's the time you place the calcium gluconate order, was not available at a pharmacy, so that immediately thereafter you would have ordered calcium chloride, correct?
Yes, sir.
Okay, now. When do you come back and check with the nurses to see that your orders are carried out?
In this situation, I didn't have to come very far. I was in and out of the room, evaluating Mr. Allen, speaking with the nurse. So, to answer your question, yes, I would have had verbal verification.
Okay. And when did you find out that no one followed through with your order for calcium chloride for this patient?
Objection.
I never found that out.
So would it be fair to say you never checked to see whether or not the order for calcium chloride was carried out by the pharmacy and by the nursing staff?
No, sir, that's not fair to say. I'd say that I was never notified that it was not given, which was the question that you had asked. I was, as far as I know, and can recall, I received a verbal order that all of my orders were carried out, including the calcium chloride.
Okay. Did you give any other orders associated with the calcium chloride order?
Objection. I'm not sure what you mean by form. I object to form.
I'm not sure.
Okay. How's calcium chloride administered to the body?
Oh, intravenously?
IV?
Yes.
Okay. Not through a central line?
So a central line is a form of an IV. It's a central venous catheter. His would have been given, if I recall correctly, his would have been given through a peripheral IV.
Okay, hang on a second. Peripheral IV is something in the arm, in the veins of the arm?
Amongst other places, yes.
But a central line is completely different from that, correct?
Central line simply means that the line terminates within the central veins of that lead directly to the heart.
Okay. And that would be going in through one of the veins in the area of the chest, the area of the collarbone when they put in the central line? That's my understanding. If you can tell me if I'm wrong.
Well, no, that's one of the places. A central line can go in several places. It can go in the neck. It can go under the collarbone. It can be peripherally inserted and be what's called a PICC line.
A PICC line.
It can also be inserted through the femoral, which would be in the groin. You go through the femoral vein in the groin.
When you ordered the calcium chloride, how did you order it for it to be administered through what avenue?
Simply intravenously. So that would then be whatever was available.
What was available at the time you ordered the calcium chloride for Mr. Allen?
Mr. Allen had a dialysis catheter and at least one peripheral IV.
But the calcium chloride doesn't go into the dialysis catheter, correct?
It can in an emergency.
Did you order it through the dialysis catheter in this case?
I did not specify which intravenous catheter it went through.
Okay. And what's the risks of putting calcium chloride in through a standard IV?
Well, with anything that's put in through a standard IV would be extravasation into the tissues, which would be leaking out of the vein into the tissues.
Does calcium chloride present a particular danger if it extravasates through the vein into the tissues?
Not to my immediate knowledge, no, not that comes to mind.
So when you ordered calcium chloride, you did not order a central line for Mr. Allen, is that correct?
No, sir, that would have posed an unnecessary delay in his treatment.
How long does it take to install a central line?
Overall, from beginning to end, it would take, on the short end, 20 minutes. If you insert it sterilely, which is the standard of care.
Have you inserted central lines in patients before you undertook Mr. Allen's care?
Yes, sir.
So you had the skills, education, and expertise in order to place a central line into Mr. Allen's body to accommodate the calcium gluconate at the time you ordered the calcium gluconate.
Objection.
Is that correct?
Could you ask a question again? I'm sorry.
You had skills, education, training, and experience to have placed a central line in Mr. Allen's body at the time you ordered the calcium chloride.
Objection.
I had the skills, training, and knowledge, yes.
Then you made a choice not to order a central line for the administration of calcium chloride at that time. Is that correct?
Objection.
Central line would have been, again, an unnecessary delay in treatment for him.
And you considered that and then made a choice not to order a central line, correct?
I did not order a central line. He had a dialysis catheter in place that would have acted as a central line.
Okay. And how would the nurses know to use a dialysis catheter or one of the existing peripheral IVs for the calcium chloride if you didn't instruct them?
Objection.
Well, the nurses have access to pharmacy instructions regarding safety and route of various medications, as far as if it's advised that it go through a central line versus a peripheral line, and then they would clarify that with the physician.
That would be you.
That would be me. And in this case, although I don't recall specifying where to administer the calcium chloride, the hemodialysis catheter would have been used in the event that the pharmacy recommended not going through the peripheral IV.
Why would the pharmacist recommend or not recommend to go through the peripheral IV? How would that happen?
Objection.
Well, it would be on the usually within the system, in the Pyxis system, the medication system that the nurses receive, that they would receive an order that they go through a central line versus a peripheral line.
And that would be the pharmacist modifying your order with respect to the avenue of administrating the medicine, correct?
Objection.
No, it would be a recommendation.
Recommendation. And then does the nurse would have to then contact you to figure out which method to use?
Yes.
Now, how soon after the administration of calcium chloride, if it was actually administered in this case, do you expect to see a drop in strike that. Calcium chloride wouldn't affect the drop in the potassium levels, correct?
Correct.
Okay, so calcium chloride only stabilizes the heartbeat.
Correct.
Okay. How shortly after Mr. Allen was administered calcium chloride, if it had been given to him, would you expect his heart rhythm to stabilize?
Well, I wouldn't necessarily expect to see a change in the EKG. I would merely expect to not see a worsening, and that effect would be immediate, but very short-lived.
Okay. So the immediate life-saving effect on his irregular heartbeat would be seen immediately after the administration of the calcium chloride. Is that an accurate statement?
That's an accurate statement.
Okay.
But it would also be, again, short-lived.
All right. And for how long would you expect this to be, to his condition not to get worse after the administration of calcium chloride?
Less than 30 minutes.
Okay. Could you have given him another dose after the first 30 minutes?
Yes.
Okay. And for how many more doses could you give him in order to prolong this stabilizing effect of the calcium chloride?
That I don't know.
Okay. After you ordered the calcium chloride, when did you check back on Mr. Allen to see if his heart condition had stabilized from the calcium chloride that you say you ordered?
I was continuously checking on him during this time.
Okay. So if you're continuously monitoring his condition and checking the medical chart, then you would have known that calcium chloride was never given to him, correct?
Objection.
No, sir.
Okay. Why, if you're continuously monitoring his condition, you would not have been able to, from your own observations, or from speaking with the nurses, or from reading the chart, not have realized that he never received the calcium chloride?
Objection. That's not objective form and foundation.
We don't have any evidence that he did not receive that. You know, I would have had verbal confirmation that he received the calcium chloride, as
Well,
we had said before.
We do have evidence that he never received the calcium chloride because there's not an order for the calcium chloride, and there's no medical administration record that a nurse ever gave it, correct?
There's no record, but again, as I said, sometimes in emerging conditions when things are happening rapidly, the records may not reflect everything that happened. And therefore, we may not have documented that he received it, though he did in fact receive it. It's just,
Are you claiming the medical records are in error in this case with respect to the calcium chloride?
Objection as to form.
I'm not claiming any error in the medical record. I'm merely implying an omission.
Well, and, Doctor, if you're not claiming there's an error in the medical chart, and we're relying upon the medical chart, then the medical chart clearly indicates that there was no order for calcium chloride by you, and there's no medical administration of that medication for this patient, correct?
Well, objection. He's asked and answered that. Go
Your
ahead.
lawyer
I'm not
can't-
sure what the question is, other than what he's already answered.
I guess I would ask you to repeat the question.
According to the medical chart, there's no evidence in the chart that you ordered calcium chloride, and there's no evidence in the chart that the nurse administered calcium chloride, correct?
That's correct.
Objection.
Now, are you claiming that a nurse actually administered calcium chloride to Mr. Allen?
Yes.
Okay. When did this happen?
This would have happened immediately following my discussion with the pharmacy regarding the absence of calcium gluconate.
Okay. And would the medicine be brought to the floor on a stat basis, or is this medicine that you already have pre-mixed on the floor?
That I don't recall.
Okay. And on a stat basis, you believe he would have received this medicine within 15, 20 minutes after the time you ordered it?
Correct.
Okay. And what I'm trying to say is, because you were constantly monitoring him, what effect did you see? What stabilizing effect did you see anywhere in the record as a result of the administration of the calcium chloride?
Well, if your question is what stabilizing effect did I see, I saw that the rhythm on the telemetry was not worsening.
And you attributed that to the administration of the calcium chloride?
I attributed that to a combination of the medications that I had administered at that time. He had received more than simply calcium chloride.
Well, the Kexlate wasn't administered until 15 minutes after 1. If we go along with your timeline, the calcium chloride would have been administered before that time, correct?
Correct, but the other more rapidly acting medications would have occurred at the similar time.
Okay. What are the other more rapidly acting medications that he received at the same time?
Well, again, it's the insulin with glucose, the sodium bicarbonate, the albuterol.
Does the insulin with glucose, the sodium bicarbonate, and the albuterol have a stabilizing effect on the heart the same as the calcium chloride does?
Objection.
It does not stabilize the membrane of the conducting cell in the heart, but it drives the potassium out of the bloodstream into the other tissues, into the other cells, so that there is a transient decrease in the amount of potassium that the heart is seeing, therefore decreasing the effect of the potassium on the heart.
How quickly does the insulin glucose administration drive the potassium back into the cells so you see an effect?
Very quickly,
Give me an idea.
less than 30 minutes.
All right. And how about the sodium bicarbonate? How fast does that drive the potassium back into the cells to have an effect on the heart muscle itself?
Once again, it's going to be within 30 minutes. They all act very rapidly.
And how about the albuterol?
Again, within 30 minutes.
And can you quantify the effect that each of these had on driving the potassium back into the cells to have a stabilizing effect on the heart muscle?
No, sir, that's not possible.
So why do you say, if that's not possible, then why do you say the stabilizing effect on the heart muscle was from the calcium chloride and not these other medications that were being administered close to, if not at the same time?
Well, that's not what I had said.
Okay.
I had said the opposite. I said that it was the combination of all of them that had done that.
So is it possible or impossible to tell us which of these medications, calcium chloride, insulin glucose, sodium bicarbonate, or albuterol, had the effect of stabilizing the heart muscle? Is it possible or impossible to tell that?
Objection.
It's impossible to tell which one specific medication had the most effect on stabilizing the heart.
If he hadn't been administered sodium chloride, would you still see the stabilizing effect from the other medications that you ordered and he received?
Potentially.
So what I'm trying to figure out is why you specifically believe that the calcium chloride was administered.
Objection. Asked and answered.
You did. You did, I know, a couple times. But I'm trying to figure out in your mind, why did you believe the calcium chloride had been administered when there's no orders in the chart? Is it
Objection.
something you remember, or it's just an assumption upon your part because of his medical condition after these medications were administered, if in fact calcium chloride had been administered?
Exception is the form, foundation, and repetition. Go ahead.
So the question was, what makes me believe that it was in fact given?
Yes, sir.
Objection.
A combination of my practice, the standard of care, and what's given in an emergent case of acute hyperkalemia, and my recollection of my conversation with the pharmacy and my nursing staff.
Okay. We talked about your recollection of the conversation with the pharmacist, but I didn't hear any conversations you had with the nursing staff regarding the administration of calcium chloride. Do you remember any of those conversations at all?
Well, I had mentioned several times the verbal confirmation of things having been given, and so those would be the conversations for which I would speak of.
Well, are you telling me you spoke to a nurse and asked the nurse whether or not she gave the calcium chloride that you ordered?
Yes.
Okay, which nurse did you speak with?
That would have been the treating nurse. I believe it was Michelle Frock.
You remember a specific conversation with Michelle Frock where you asked Ms. Frock, did you administer the calcium chloride that I ordered for Mr. Allen?
Asked and answered. Objection. This is about the 10th time we've gone through this.
No,
One more time, and I'm going to lose my patience. Go ahead. You can answer.
Okay. I can't say that that specific sentence was uttered from my mouth, but I can say that I had multiple conversations with Nurse Frock during the course of this several-hour event. This is not something that happened in an instant of time. It was an ongoing treatment for Mr. Allen that, had it not been ongoing, would have surely, resulted in his death. And so, we spoke on multiple occasions about what we were doing, what had been done, what could be done further for him. And so I don't recall a specific question that I asked her where I said, did you give that calcium chloride, or did you give the albuterol? I did ask, how are we doing? What has he gotten so far? And all of those were answered to me in the affirmative. And so.
Can you tell, was the calcium chloride, would it be in an IV solution?
I don't recall if it would have been in an IV bag or if it would have been a vial that would have been mixed up That I don't know.
And how long does it normally take for one dose of calcium chloride to be administered to a patient?
That I don't know. I don't know if if it's a rapid push or if it needs to be over 5 minutes. They have, again, that's part of the notifications that the nurses get when they obtain the medication to give the patients.
Do you remember how you ordered it in this case?
That typically is not part of an order that was given over X number of minutes,
Okay.
especially with a verbal order such as this.
Well, wait a minute. I thought it was, did you order it through the computer?
No, the calcium chloride would have been a verbal order.
A verbal order. All right, explain how that works, because I don't know how it works, doctor.
I'm going to object to this continuing line of question. First of all, there's been no evidence whatsoever the absence of sodium chloride, whether or not it was given, made any difference in the outcome in this case, first. Secondly, we've spent lots of time on what I think is the same topic over and over and over again. So I want a continuing line of objection, so I won't interrupt. I'll let you go ahead and answer the question, but I object to any further questions about calcium chloride.
Sure. So the way a verbal order works is that the physician speaks to the nurse what he would like them to like the patient to receive. They repeat it back, and then they proceed with the order from there.
Okay, and then the nurse would have to document the verbal order, correct?
Objection.
Potentially, but again, as I said before, not all things can be documented in emergent situations.
Wait a minute, and I just want to be sure. I thought you said you did talk to the pharmacist about the calcium chloride, correct?
Objection. Again, this is the third time on this issue. Go ahead.
Yes.
All right.
Can we take another real short break?
Sure.
Off the record, going off the record at 12:48 p.m.